All right. When you read this slide, you say, this can't be real. Please wipe off blood pressure cuffs to reuse between patients. We won't have any more since January. Get ready. This is the real world. Okay? We're going to talk about neurology, but let's first talk about shortages. You will have shortages. I have shortages through my career. We went through the great lorazepam shortage where we had to give people alcohol for alcohol withdrawal because guess what? We didn't have any benzodiazepines in the house. We went through morphine shortages where anesthesiologists were doing is giving high doses of magnesium to help control pain during surgery because there was a shortage of morphine. We went through bicarbonate shortages. We went through CloudStrike where it took out our medical records. You will have these. Guess what? The world is interconnected. Drugs are just not made in the United States. They're just not made in Switzerland. They're just not made in Sweden. They're made, they're international production. A part is made and shipped and made around the world, and then it comes together to the final product. Did you know that snake anti-venom is made in 3 different countries? First, you get the venom from the actual rattlesnakes in the United States. Then they're taken to special sheeps that are only in New Zealand, and these sheeps help produce, and then it's taken to London, England, and they're extracted out. So 3 different countries to make snake venom. And that's just one of the more simple things. There are other medications that are used in multiple countries to make for production. Now let's get started in neurology. Every year, almost 800,000 people in the United States have a stroke. Approximately 330,000 Americans have subarachnoid hemorrhage. The subarachnoid hemorrhage mortality is huge. Anywhere, we're going to say about 50%. 50%. But look at this fact right here, and I just love this fact. Our brain is about 3 pounds of blob, about less than 2% of body weight, but consumes over 20% of our energy consumption and oxygen. 20% of our energy and oxygen goes to the brain when you think about that. We have 86 million neurons. Probably hospital administrations have less than half of that. We have 100 trillion synapse connections that can rearrange. Remember, I want you to remember this term neuroplasticity that allows our brain to adapt and recover from injury. So why is this so hard to understand? Neuro is going to be tough. Okay, neuro is tough because it's uncomfortable. It's very hard to see anatomically, and it's hard to think about. And either you get it or you don't. And we're going to try to get this, and we're going to get this through here. Remember, memories are not made in comfort zones, and I don't want you to think that neuro is comfortable. Neuro is going to be uncomfortable, and we're going to go through it, and we're going to make it comfortable for you. All right, we have a 42-year-old female with no past medical history, female with had pneumonia. She's placed on cefalopine. Remember that before the studies were actually read, where the people just looked at the end of the study, and they actually didn't look at the study where the author said, hey, we need to do more research. We started to take cefalopine because the EMR suggested it to us, and guess what? The EMR was wrong. And in cefalopine, this patient had a worsening AKI, and now they're altered. What was the answer to this question? I've already told this to you. Question, we have suspected for non-convulsive seizures. We'll discuss this non-convulsive seizures in this lecture because it's very important. Now we come over here to a woman, and this, we're going to go here. Remember, it's not a fair board review. This is an unfair board review question, and so you can complain all you want, but you're going to learn, and you're just going to get over it and say, you know what, none of these board questions are ever going to be fair. It's going to hurt my feelings, but I'm going to pass, and I'm going to get better and take care of patients. Which of the following is the most appropriate next diagnostic step? Brain MRI, continuous EEG monitoring, and empiric administration of IV levetiracetam, lumbar puncture, serum ammonia level. All these sound great. What's an EEG? EEG is where we monitor people for seizures. Basically, it's an EKG of the brain. We'll call it that very simply. You're going to see them put this little neural net on people's head, and then they're going to see this nice little machine, the video machine. They can have a video recording on there, and you're going to see the wavelengths, and we're looking for seizures on this. This is a 68-year-old woman with history of hypertension, recently subarachnoid hemorrhage. Now, she's had subarachnoid hemorrhage, so I want you to think her brain has been remodeled. There was blood product sitting there. She's admitted to the ICU. She's noted to be unresponsive, but with not any convulsive movements, so she's just laying there. Neurological examination, so reveals no focal deficits, but she has intermittent displays of lip snapping and eye deviation. Her metabolic panel and neuroimaging are unremarkable. What are we going to do? We're going to do continuous EEG monitoring. What does this patient have? Non-convulsive seizures. Now, in this question stem, they did something nice. They said lip snacking and eye deviation, meaning the eyes going back and forth. guess what? In the real world of non-convulsive seizures, you may not get those wonderful, subtle physical exam findings. Sometimes you just can't. And we've done a horrible job as a community on non-convulsive seizures and catching them and then treating them. We need to get early EEGs because it's essential for diagnosis and further management. If we do not get on these and treat these early, the patients die. Here's an EEG. You're not expected to know EEGs. I'm just giving you one that shows seizures. You kind of look at it, almost looks like VTAC, a little VTAC of the brain. I want you to think of seizures as a storm in the brain where this patient's brain has run a million marathons, okay, and their brain is worn out. Now, here's an EEG. This shows just background slowing. You are not expected to know this. This is why neurologists get their fellowship, is they learn how to read EEGs. You are not expected to. This is an informational portion only. Here is background slowing. Here we go. We're going back to this. We're going back to this, and why? Because this is an egregious thing that happened. Is piperacillin tazobactam versus cefalpine. I know we discussed this in the ID section. This is a refresher. Piperacillin tazobactam is great for anaerobes, enterococcus faecalis, lower ration of C. diff, maybe better mortality. Cefalpine, the problem is people were said to take cefalpine because the combination of piperacillin tazobactam with vancomycin could cause a worsening AKI and increasing the patient morbidity, mortality. The study was redone. That study was in 2002, that says that piperacillin tazobactam was the work of the devil, basically, and you went into your EMR and you went to prescribe piperacillin tazobactam and you happen to have vancomycin there and said, provider, are you aware that you can cause injury? Then everybody got scared. They stopped using piperacillin tazobactam and used cefalpine. And guess what? Cefalpine itself is not pure. It's not the virgin. It's not beautiful. It does, yes, it can cause the CNS. It can cause neurotoxicity and can induce non-convulsive seizures. Why are we saying this so many times? Because we see people get hurt. Cefalpine versus piperacillin tazobactam in adults hospitalized with acute infection. High quality study. This is the ACORN study. This is a randomized clinical trial. Great ID doctors say this is what we should do more of, is studies like this. Study hysteria happened prior in 2022, where we were told that piperacillin tazobactam plus vancomycin was the work of the devil. It could be, but it really isn't. And the reason why they did that is they didn't even read the full study that the authors had discussed, that they needed more information, and they just went to the bottom line. Don't be a bottom line warrior. Go and read the full studies for yourself. Use this up here and get more information. If you can't use this up here, go and read. There's going to be other great providers that are going to give information on these topics, on these studies, and help break them down instead of just reading the bottom line. The answer, among hospitalized patients, treatment with piperacillin tazobactam did not increase the incidence of AKI or death. And guess what? We mistreated people for roughly 2 years because we did bottom line warrior study analysis instead of reading the full studies and thinking for ourselves. Treatment with cefalpine resulted in more neurological dysfunction. You're going to see this more in older patients. You're going to see it when they have AKIs. Let's go back to seizures because we're in that neurology unit and we're going to talk about seizure pearls. Initiate. So somebody has a seizure. What are you going to do? And what can lower seizures? What some medications can lower seizures? This is important. Tramadol can lower seizure threshold. You can develop serotonin syndrome from a side effect of tramadol because remember, people don't want to give opioids, so they give tramadol, which still is an opioid, but they feel it's a great, safe opioid, but it may not be. Bupropion can lower seizure threshold. Haloperidol can lower seizure threshold. Remember, we talked about the carbamazepines can lower seizure threshold. And then beta-lactam, certain ones. Maybe we'll consider even cefalpine as being a higher probability of lowering seizure threshold. So we have a patient with seizures. Initial treatment is going to be IV lorazepam. 4 milligrams should cover us. If you do not have IV access, you can give IV mirtazapine, which would be 10 milligrams. Still seizing, we give fosphenytonin, which avoids, okay, why do we give fosphenytonin versus phenytonin? Fosphenytonin avoids AV block and hypotension compared to phenytonin. Fosphenytonin, you still can have hypotension. Is still continuous phenobarbital. At some point, this patient is probably going to need to be intubated. If seizure still continues, can you do intubation and generalized anesthesia. Reasonable to stop anti-epileptic medications in patients with epilepsy that are seizure-free for 2 to 3 years. You do not have the ability to report to the DMV, okay? This is, some providers can get screwed up on this. They feel that they need to report to the DMV. Yes, we don't want our seizure patients driving. You need to encourage them to report it themselves or to not drive, In the US, that's a big deal when you can't drive. Many of our cities do not have the proper mass transit so that these people can live normal lives, so it becomes a big burden. First-time seizure, do not treat unless status epilepticus or a abnormal EEG. You would treat on the second. Seizure pearls. Treat for first-time seizure if age greater than 65 years old. Focal finding in the EEG, like we discussed, or MRI shows a lesion. Head, unless they have a history of head trauma. Anytime somebody has a traumatic brain injury, increased risk for seizures. I want you to think about that the seizures, that after they've had a head injury, their brain has been remodeled, like their house has been remodeled, so we're going to have different problems with our neurocognitive, but also we can have increased risk of seizures. We can have a postictal Todd's paralysis. This is a postictal hemiparesis. If someone comes, they have seizure on one side, and then they can have a postictal hemiparesis. Inpatient EEG monitoring is indicated with patients whose seizures who have not responded to multiple medications. I want you to think and work at places that have EEG monitors. If you don't, I want you to push them to get them, because guess what? I've never seen a patient die of an EEG. Now, does it increase costs? Yes, it increases costs, but we're working to take care of patients, and we want to get a better diagnosis on our patients. Are EEGs perfect? No. They don't have as great a sensitivity as we'd like them to be. As we do them longer, that's why you see these patients may be on them for several days, is it may have a better probability of picking up seizures, or it may have a better probability of picking up of PENS, which we'll talk about. Now, a patient from Mexico with seizure, this is a seizure pearl, can have cystic lesions on imaging. Consider cysticercosis. Remember, this is from the pork tapeworm with Tinea salinum. Now, this is in other countries. The analysis done in latest studies of pork meat, there has been really no incidence of it. Basically in the US, we've done a great job. Does that mean that there is none in the United States? It means there's a lower probability. Albendazole is only for the live tapeworm. Calcified lesions use anti-epileptic medications. So meaning if in these lesions, albendazole can be used if they have a live worm. If they don't have live worms, in calcified lesions, they can get anti-epileptic medications. Types of seizures. Seizures are classified into 2 groups. And this may be different than you learned because the nomenclature changed. Generalized seizures affecting both sides of the brain. These are generalized seizures affecting both sides of the brain. And then focal seizures are partial seizures. So what are examples of generalized seizures affecting both sides of the brain? Absence seizures, or these used to be called as petit mal seizures. Absence seizures, just staring at somebody. This is when you ask your hospital administrator for a raise. You ask your clinical administrator for a raise, and they just stare at you like this. They're having an absent seizure. This is a good example. Another would be a tonic-clonic seizure. These used to be called grand mal seizures. Tonic-clonic, both sides of the body, twitching both sides of the body. Focal seizures can be simple focal seizures, twitching or change in sensation. Like some people will have like a deja vu feeling or smell. They smell something burning, smell popcorn, something like that. They have a taste or sensation. They can have complex focal seizures where they can be confused and not answer questions, like your administrator after you ask them for a raise. You can have secondary generalized seizures, first a focal seizure, then a generalized seizure. All right, let's go over treatments of seizures. And we're going to spend time learning the side effects, and that's what the boards hit a lot, and that's what you're going to need to know. A lot of these medications may be managed by a neurologist, and you're assisting in managing the side effects or understanding if the patient is having side effects to refer them back to the neurologist. We're going to go by spectrum broad, all seizure types: lamotrigine, levetiracetam, valproic acid, topiramate, zonamide. For narrow, for focal seizures, carbamazepine, gabapentin, oxycarbazepine, phenobarbital, phenytoin, pregabalin, and primidone. For absence seizure, there's just one, ethosuximide. So initial seizure workup, you want to get serum glucose, CBC, CMP, and EKG. Look for causes of provoked seizures: alcohol or drug withdrawal, drug intoxication, hyponatremia, hypernatremia, hypomagnesemia, hypocalcemia. Get a urine tox screen, alcohol level, anti-epileptic drug levels if they're taking these medications. You discuss family history, childhood events, head trauma history, CNS lesions. Do they have malignancy or no malignancy? Birth injury. Let's go back real quick. EEG should be done at admission or soon after admission. If not, return to baseline within 15 minutes post-seizure. I really recommend that you get these EEGs as soon as possible. Remember, this is the crazy thing about seizures. Even though we think we're good, we're not good, because approximately 30 to 40% of patients with epilepsy have seizures that cannot be controlled with anti-epileptic medications at optimal doses, even after 2 appropriate trials. That's amazing, is that we suck in 30 to 40% of these patients. Counseling. Avoid heights, heavy lifting, swimming, bathing alone, and discussion of driving. Remember, you can't tell the DMV, but you may tell them, hey, probably don't drive. You don't want to, maybe don't even use it for themselves. So they say, I don't care what happens to me. Maybe they care what happens to their children if they're in the car, or the person on the road next to them. Maybe they care about that as a humanistic ultra. Restriction on driving, all patients, unexplained loss of consciousness, even the diagnosis unclear. This is very important. You can look at this as state laws regarding seizures to the DMV vary per state and how long they can't be driving. You can find this on epilepsy.com in their driving laws. This can be very important for you as a provider. Most require 3 to 12 months free seizures before driving event. Different states vary. California can be 3 to 6 months. New York is 12 months. Those with single unprovoked seizure with normal EEG and MRI, 2-year reoccurrence is roughly 30 to 40%. Broad spectrum AED, generalized and focal, lamotrigine, levetiracetam, topiramate, and valproic acid. Levetiracetam is usually the first-line drug. Started quickly, few interactions, and well tolerated in older people too. Broad spectrum, those are broad spectrum neurospectrum AEDs. Carbamazepine. Where else can we use carbamazepine? What other medication, what other disease can we help treat? For our trigem neuralgia, remember when we have the facial nerve pain, gabapentin we've talked about. It's used more for non-seizures than it is for seizures. We talked about the side effects of this. You can have swelling, increased risk of fall, peripheral edema, increased risk of falls, fogginess. Oxycarbamazepine, phenobarbital, and phenatonin are also neurospectrum. Carbamazepine is a good choice, cheap option, it's well tolerated. Side effects can be sedation, ataxia, leukopenia, hyponatremia, aplastic anemia. Hyponatremia can be important. All right, let's talk about anti-epileptic drugs for the following conditions. For pregnancy, levetiracetam, lamotrigine. Elderly, levetiracetam, lamotrigine, kind of seen this pattern, right? Liver failure in pregnancy, levetiracetam. Gabapentin can also be used. Remember, the side effect can be sedation, edema, weight gain. You need to watch an acute kidney injury. Gabapentin levels can be elevated. Chronic kidney disease, lacosamide probably is going to be your first line. Levetiracetam can build up and have side effects. Adverse effects of anti-epileptic drugs. Lacosamide can have sedation, ataxia, diplopia, can have PR prolongation on your EKG, bradycardia, AV block, and a rash. This rash can be serious. You can have serious skin disorders of the skin, everything up to Stevens-Johnson syndrome. Remember, Stevens-Johnson syndrome is less than 10% of the skin. When we have greater than 30%, it's 10's disease. You can also have to worry about DRESS syndrome, which is drug reaction with eosinophilia and systemic symptoms. So lacosamide can have serious skin reaction. Levetiracetam can have irritability, sedation, depression, psychosis, anemia, thrombocytopenia, and leukemia. Oxycarbazepine can have sedation, ataxia, leukopenia, hyponatremia, rash, Stevens-Johnson syndrome, and DRESS can also occur in oxycarbazepine.